Hi, my name's Carly Edgar. This is a presentation about my research into Eastern Palliative Care's biography program. My PhD thesis is called Witnessing the Theatre of Life, Storytelling in Palliative Care. I acknowledge the traditional custodians of the lands where I live and work, the Wurundjeri people of the Kulin Nation, the very lands the La Trobe campuses are located on, and the Wurundjeri people as the traditional custodians of the country on which the EPC offices are. I acknowledge and recognise the ongoing connection Indigenous and First Nations people have to their land, and pay respect to their leaders past and present. This research was supported by a La Trobe University research scholarship funded in part by Eastern Palliative Care. I had 4 supervisors over the period: Dr. Bruce Rumbold, Dr. David Azul, Dr. Fiona Gardner, and Dr. Susan Finesse, and my main EPC contact was Crystal Wallace. So I'll be talking about my research. I'll give a brief overview and then focus on a particular aspect that we think is relevant for this group. So there were 4 research participant groups. One of my aims was to gather information from a wide spectrum to obtain information from as broad a perspective about the program as possible. So clients and storytellers were one group, volunteer biographers who facilitate were another, all EPC staff were invited to participate, and the primary carers listed as the carer of a client of the biography program for more than 13 months and up to 5 years prior to the start of the research were also invited. I gathered 2 sets of interviews and a series of surveys, but my main focus was on the case study interviews as they were the most personal method of gathering information, and it also replicated aspects of the biography program which seemed suitable. And there were 37 interviewees in total. So as part of my thesis, I presented various findings or results. These included a short history of the biography program and a description. The description of the program was supported by what I called factions, which are fictional stories drawn from factual information. They were short scripts drawn from the stories I was told, sort of fly-on-the-wall experiences about the biography program experience, but without using anyone's real information. I also used these scripts to introduce topics and concepts, both potentially positive and challenging. Another finding was a series of researcher observations where I discussed various themes, drawing directly from the participants' information. Themes included things like biographical disruption, illness narratives that many wish they or their loved ones had started earlier, legacy leaving, and unexpected impacts. Another finding were the stories of the participants. Their stories alone are worthy research results, as they provided great insight into the program and palliative care. I included direct quotes and research poetry throughout the thesis. I also developed various types of research poetry, which draw directly from interviewee transcripts. Unfortunately, I won't be spending a lot of time on either of these. They are just some brief examples. Another example are that research poetry and the factions led to producing lengthier scripts that draw directly or more directly from interviewee transcripts than the factions. They are as yet untested and unworkshopped scripts, but provide an example of how research may be transferred into potentially more broadly applicable forms of communication, which I think is really important for palliative care in particular and healthcare in general. So another key result was the articulation of the philosophy of EPC's biography program. I was engaged in a level of research that hadn't been carried out by anyone into this specific program, and hopefully by articulating the underlying philosophy, I hope that further research might build on it. Part of the reason for its development, the philosophy, came about by learning about the history of life storytelling programs more broadly. As I learnt the historical development, I identified that there were different types of traditions of life storytelling programs. This led me to realise that the tradition EPC's biography program falls into has very little literature on it or research into it. By articulating the traditions, I could identify the similarities and differences between the biography program and others. So by articulating the traditions, it was also relevant so that I could determine what literature was most relevant. There are both huge amounts of literature broadly into life storytelling programs, but very little into this particular tradition and the biography program specifically. So I had to determine what information was most relevant. The traditions helped me exclude literature about group programs or those with a social focus. This is relevant and connected, but ultimately outside of my scope. This immediately eliminated what we could describe as an entire tradition of reminiscence programs for social engagement. I included literature about programs delivered primarily in a one-on-one configuration, and I broadened palliative care to include programs for older adults and those within residential aged care. The flexibility of the biography program approach to storytelling was an area I needed to be flexible about, as was that it was facilitated by volunteers. So I included programs with specific protocols and those facilitated by healthcare professionals. So still a lot of literature, but it came quickly clear that the most recent literature was dominated by two specific programs, Structured Life Review and Dignity Therapy. So Structured Life Review is a specific program which helps participants review their life. It is delivered over about 8 sessions, which follow a set process of what's covered each session. It is generally offered to older adults, often within residential aged care, and traditionally there is no legacy document. Dignity therapy is a shorter intervention, only 1 or 2, although sometimes up to 4 sessions. Clients choose to answer questions from a prescribed list, and their answers then form a legacy document. Both interventions are traditionally facilitated by healthcare professionals, nurses, counsellors, psychiatrists, or spiritual care workers, for example. So this isn't to say that there isn't literature about other programs. There are, and there is quite a lot. However, the most substantial and consistent research has been conducted into these particular programs. The research also regularly draws from a similar pool of literature, and they are regularly compared, sometimes even conflated as being similar, despite having different intents. I identified that these two programs therefore represented not just other individual programs, but also two distinct traditions of life storytelling. Structured Life Review represents the tradition of life review. Dignity therapy represents what I call the tradition of focused life storytelling, which are programs that are developed to address a fairly specific purpose. So they are focused. For example, and quite generally, dignity therapy was developed out of research into dignity into those receiving palliative care. But EPC's biography program doesn't fall comfortably into either, representing a third and less commonly referred to tradition. Publications about it are slowly increasing in the last 5 to 7 years or so. In this tradition, storytelling is guided by a facilitator, often a volunteer. It is flexible in method and produces a legacy document. So there are similarities between all three traditions, but there are also differences. I found that some of the similarities lie in some of the issues raised in various literature about issues such as difficulties with family members, questions about what to do with stories when they don't satisfy everybody, the length of time that transcription takes, and that sometimes the programs don't translate well between cultures. Issues may be found in nearly all three traditions. In the literature, though, there is rarely specific or practical solutions offered. As I analysed the information I had gathered, I found that EPC's biography program did have some practical solutions, even though my research was not necessarily focused on determining exactly how they do those, I still gathered a lot of information. However, the way that the issues were addressed were not ones that could be universally applied as solutions. I couldn't just provide a table of how to address each concern. The solutions were often contextual. And in my description of the biography program, I also couldn't provide a protocol of how it functioned, because while there are specific protocols, they have little to do with the actual storytelling process. The protocols tend to have to do with healthcare or safety elements, or with establishing good practice, while still allowing for the possibility that things might need to adapt in the storytelling process. The storytelling elements are always adapting and being individually applied. The process is influenced by new ideas, technology, and other solutions. How the program operated when I began this research and how it is potentially operating now are already potentially different. Rather, the information I gathered seemed to provide a more fundamental perspective of how and why it operated the way that it did. And this foundational perspective also seemed to explain how and why EPC's biography program worked and continues to be delivered even without any specific process to measure its impact. Unlike many other studies and programs, EPC doesn't require any sort of formal assessment or measurements to continue implementation of the program. In contrast, a lot of research has gone into trying to establish specific benefits of, say, dignity therapy. Some of it has seen significant results, but not always, despite how well it is nearly always received by participants. Some literature suggests that this may be due in part to assessments using inaccurate tools, and things like spirituality measures would be more effective. And this approach is now producing more positive results. The need, though, to produce significant results from any perspective, spirituality or others, such as mental health, to prove its worth in being offered to clients, for example, presupposes that dignity therapy and others are a healthcare intervention. Therefore, success or failure, or perhaps the choice to fund implementation, is reliant upon such results. EPC requires no such results, nor did the program from which the EPC program was originally based on. The program that EPC's biography program was originally based on, and the organisation who provided the initial training to those who implemented it within EPC, produced just one single paper about their program. They stated that they felt it was inappropriate to put their patients through any such assessments, and also that if offering whole person care, it would be difficult to know exactly what was actually accomplishing any benefits, taking a deliberately whole person view. All of this seemed important: the lack of assessment, whole person palliative care, and its flexible facilitation method. I came to think that the best way to explain this intersection was through describing the philosophy of the biography program, rather than trying to develop any sort of protocol or delivery. The philosophy I present came out of my analysis, drawing from all 4 groups. I noticed both what had worked, but also when things didn't seem to work so well. There are 4 parts, and while they may seem quite basic, the last one might be a surprise. Each part is relevant for all of those who are connected to the program, not only clients, although they are the main focus. The first part is that it is person-centered. Perhaps obvious, but deliberate. It's not client or patient-centered, but person-centered. While the client is the most significant member of the participants, everyone involved is recognised as important and worthy of care: volunteers, family, and staff. This language recognises that while the client may currently be a patient, this is not their sole identity, nor is being a volunteer the sole identity of biographers, nor that of staff for staff. It recognises also that our dignity does not decrease along with our health, age, or ability to engage in our valued roles. Again, applies as significantly to volunteers as to clients. It highlights also that we all have a life worthy of telling, and that the stories told may include the full scope of life, or at least the aspects the storyteller chooses to include. The second part extends this, the recognition of lifelong human development. It does not matter what stage of life we are in, what our abilities are, or how they may have changed. We can all be engaged in living life, growing, participation, no matter where we are or what's changed, even if we are near the end of our life. It allows for participation to be for growth or review if the client wish, but also for distraction or social connection. And again, this applies as significantly for volunteers as clients. Volunteers come with knowledge and experience and require specialist training and ongoing support to do their role. The third is that the program is delivered within its relationships. While a duty of care is extended first to the client, this does not detract from a duty of care and from being in relationship with all others involved. This central relationship between client and volunteer is supported by the relationship between volunteer services staff and volunteers, and potentially volunteers and other volunteers. This acknowledges that working within relationships when there are 10 volunteers and 100 require different approaches, such as the development of the networking groups to help volunteers connect if they wish. It's also the recognition that volunteers come to the program with already established lives. They both bring knowledge and experience, tapping back into lifelong learning, but also they are currently living their own life, which may impact their volunteer role, and they also require ongoing support throughout the process. It also recognises that life stories are told in relationship within the storyteller's context. Stories are also facilitated with a delicate eye and ear, volunteers supporting the client, and the story they want to tell, while possibly at times gently asking them if they really do want that in permanent print, or perhaps noticing that there are people or parts of life missing from the story, or maybe that it could be quite lovely to be a little bit more specific about what they really love about their partner. This is an adaptive process that requires the volunteer and storyteller being within this storytelling relationship. The final part was the most difficult to clarify. It is both fundamentally important but potentially surprising within a healthcare industry where life storytelling programs are commonly referred to as interventions with quite a utilitarian focus. It's that the process is creative. Not just part of the programs are creative, such as the designing of the front cover or the editing skills required, but that it is an inherently creative act. The client becomes a storyteller, a performer of sorts. The biographer becomes a creative collaborator, perhaps co-performer, perhaps editor or interpreter. The space forged between the client and the biographer is creative, as is the space they go on to create within the written story, inviting others into what has become like a script. The development of relationships is creative. How the volunteer elicits storytelling is creative, and the process can creatively adapt to the relationship between client and volunteer within the client's context. I eventually decided that the best way to describe this is that it is a little bit like a theatre company that works backwards. Rather than working towards a physical performance, the storyteller starts with a physical performance and works backwards to a written script. But the essence is still the same, biography program or theatre. It is a collaborative relational creative process. The various members of the program inhabit various theatre roles, from the production company of EPC to the directors of the volunteer services to the actors of the storytellers. Some roles merge and morph and change as required. This is small, local community theatre that adapts to the context, the interest, the performer, the resources. It is amateur theatre, using this word in the best way possible, as those who are passionate, simply unpaid. It is a theatre company to tell stories of its community for its community. By describing the biography program in this way, I hoped to explain the space in which the program exists and how it sits somewhat outside of other normal healthcare expectations, such as traditional healthcare assessment, and how and why this still works. It is because it is not an intervention, so to assign it the specificity of an intervention would be unhelpful. Rather, to describe it as an artistic process allows for the flexibility and adaptability inherent to creativity. There may be things that frequently occur, such as many biographies being told chronologically, but the process can still vary. Clients may need help getting started, but then decide they want to theme their story or just write about a particular aspect. Some may begin to please their family and then love the opportunity to reflect. Others might begin just by talking about events, but then extend it, writing letters, planning funerals, or training their husbands up in how to care for the garden once they are gone. And it may also be a somewhat distressing but desired process, such as the man with motor neurons disease. His wife told me how difficult the process became as his condition deteriorated and breathing, let alone speaking, became difficult. He was determined to complete it, though, driven not by his own comfort, but by the desire to leave his story and letters for his family. This was more important. Or the man who wrote a very short life story about what must have been an incredibly difficult life, on the off chance that one day his estranged daughter might try to find out about him. The process of writing or reflecting could have potentially been distressing, given how much of his life was clearly absent from the story, but he wrote this for other reasons. These may well be outliers or unusual experiences, but they are no less relevant than the many who write to tell stories of migration or growing up or their youth or family or even war, travel or work. To try to assess engagement in this process could prove that well-being is generally improved for most participants, but I think that to limit the possibility of the biography program to improvements in well-being is limiting. By the program becoming a creative act, the way in which we assess the program becomes embedded within the process of creativity, including relationship and listening, replicating the main act of the creative process of storytelling and listening. It recognises that the specific ways in which the program may be implemented may change over time because it is a constantly adapting program. It recognises that the main audience of this creative act is the storyteller and then possibly also their family and their community, but that the weight of importance of each of these audience members may vary from client to client. This is creative development, art making. It is not a medical intervention. It is not even art or music therapy, which have other specific purposes. Rather, it falls within a third space, one open to anyone to participate, and one that can be adapted and moulded as it is engaged in. Therefore, it is likely best not to be assessed as a clinical program or even like art or music therapy or even as a literary genre or by the standards of theatre, no matter how I describe it, but as its own creative form that exists within and is assessed within contextual individual relationships. So it has implications for how it is implemented because it cannot be implemented like other clinical programs where all protocols are either followed or it's not delivered. Again, I recognise there are certain healthcare and safety elements that require protocols. I'm referring more to the storytelling process. It is a program that requires the ongoing focus on the development and maintenance of relationships between all participants, and where management need to understand that the development and changes are not abnormal, but in fact structurally present. That training is required, but not so that the process is set in stone, but so that the volunteers are equipped enough to be adaptable and flexible, like learning the rules in order to know how best to break them. What EPC has specifically learned about the way to address certain issues is best delivered by the experts, the EPC team, who are working daily on the ground through the training they offer. This philosophy, in contrast, sets up a foundational perspective, differentiating various aspects of the program, such as purpose and process. It is a program that is about wholeness and life, even within palliative care. The clients are never simply clients or patients or even volunteers, but people who are continuing to live, even while perhaps dying. In my thesis, I describe listening within relationship as the key way of assessing the program's worth and value. This very simple act, though, requires the relationship to listen to the participants and hear what is being said, rather than aiming to tick boxes. That's not to say ticking boxes doesn't provide worthwhile methods of assessment, but in this case, it may be inadequate. This philosophy is meant to describe how to approach the biography program, its implementations, facilitation, requirements of assessment. It recognises that there are elements that can be taught and refined, but that it is fundamentally established and delivered within its relationships and creativity. It is to recognise that it is a creative process that is founded on listening, storytelling, and trusting creative relationships. Thank you.